Let's go with the lecture. We will probably make this the last lecture of the day, and whatever questions you have, either you can interrupt me, but most likely I will have an answer for you during the presentation, so it may not be a bad idea just to hold your question till the end of the presentation. What is the objective? Mainly, I will talk about the techniques and give you some tips and how to process the specimen and assess the adequacy of the specimen. So with the ERCP, this is just a little bit background. I don't need to go through that too much. We all know that brushing burst cytology, when they ask me like, oh, you want to do a burst cytology, I just tell them like flip a coin, you have a better chances to win. Than with the burst cytology. So with the EUS, obviously, you can see that we can nicely see the mass right there, needle. Under real guidance, we can get the needle into the tissue and get some specimen and evaluate that. So what do we want from a good specimen? We want cells in there. Without cells, it's a useless specimen. We want it to be adequate not only for interpretation, but also for ancillary studies, whatever further studies needs to be done, staining or molecular studies. And ideally, we don't have to keep using like multiple needles, especially in this setting. Even in any setting, needles are expensive. So you want to achieve all the tissue or want to achieve all the targets with one needle. And what is really not desired is the blood, because blood in the specimen makes it inadequate and uninterpretable. So you're gonna hear a lot about, okay, everybody wants to do like somebody wants to do a fanning technique, somebody wants to do a wet section technique, somebody wants to use a stylet, other doesn't want to use a stylet. With regard to fanning, yes, it does work, and I'll demonstrate what the fanning mean. With suction, no suction, they both work. Some people like to use suction, some people don't like to use suction. I'll tell you what I really do with those. And then there is another question of number of passes needed. For the pancreatic masses, usually 5 to 7 are enough. For lymph nodes, it is proven that 3 to 4 3 to 4 passes are enough. We all know that EUS is really, really safe procedure and risks are really low with that. So here, before I go for into the fanning and other aspects, one thing I really want to stress is use the technique what works for you best. Okay, if I like a technique, I can assure you 100%, I can guarantee you I can do a randomized trial on that and prove every other technique useless as compared to my own technique. So it's whatever works for you, that's the best technique for you. Just remember that. And fanning is, this is just like a nice cartoon. You can see the needle going in one area. So mainly the goal is really to, like regular technique is just going back and forth multiple times in one area, like 15, 16 times. But with the fanning, you want to just go through different areas. And each area is like 3 to 4 times in 3 to 4 different areas. So that's really called a fanning technique. This is one of the examples. Just remember that if the mass is really big, it may sound like, or it may look like a fanning is easier, but it's harder to fan in a larger mass as compared to a smaller mass. So smaller the mass, easier the fanning technique. You can see that here, there's a aorta, there's a mass right there. So this is a mass where you can really do an easy fanning technique. Having said that, also just make sure that you see this area which is kind of an anechoic area. Try to avoid that. That's an area of dead tissue, necrosis itself. So here, what you really want to do is like go stick it with the needle and go into the different areas 3 to 4 times. You don't have to go crazy like a jackhammer and just like somebody has electric shock, just use it not too slow either. but kind of a medium speed, and try to go into the different areas. Sometimes it looks like it may be going into the same area, but if you change the angle or a plane little bit, even though it may be in the same area, but it usually is in the different portion of the mass, because it's a two-dimensional image you are getting, and it's not a three-dimensional. So it may look like it's going into the same area, but changing a direction usually takes care of that, of the different area. So here, this is another example. If you look at this, you see there is a huge mass. When we see that, we get really excited. We want to go right into the center of the mass, and that's where you should avoid. So here, this is all this hypoechoic area, and you can see that this is like, I shouldn't say hypo, more like an anechoic area. This is a hypoechoic area around that. So you really want to try to go into the periphery of this. So either go here or try to go there. Try to avoid this area, because this is where you're going to get a necrosis. Then your cytopathologist is not going to be really happy with you. If you don't really have an on-site, it may seem like you're getting a lot of tissue, but it really is a necrotic tissue. That's what you are getting. So try to go into one area. And if you look at that, I'm not trying to go crazy with that, trying to change the direction, go 4 or 5 times in one area, and this is and then try other portion of the mass. So this is FNA technique. I have a video of FNB technique, which is totally different from this. FNA is fine needle aspiration. FNB is fine needle biopsy, which is a core needle. A lot of people are using those nowadays, and I'll show you the technique for that. But you guys still mostly are gonna have a FNA needle. FNB needle is quite expensive. I don't know if you guys have it here or not. Acquire. What's the price of that? Same price? Okay. And what about the FNA needle? How much is that?
Depending on if you're using it's about 22,000.
Okay. So it's not same price, right?
So slim line is, it's again FNA, but it's a plastic needle. That's again for.
Okay. So this is an other video. You see, okay, I'm gonna stop it here. Do you, can you appreciate which organ is that?
That's the gut loop there, and that's the mass left side.
Okay, this is the gut loop and this is the mass. Okay, anybody else? So what is this? It's a liver, right? This is a liver, right? No, this is no. It's a liver. It's a pancreatic mass. Like a patient had a pancreatic mass, but obviously this is a liver, and this is a met, a huge met in there with the central necrosis. So it's the same concept. Maybe I guess the image may not be doing the justice, but if you look at it more and more, you see the left hepatic vein right there, and you see the big, huge metastatic lesion in the liver. So here, a lot of necrosis there. These mets are really, really cellular. You just need one pass if you are in the right place, and that would be all the cells. So they are very, very cellular, and just you need to be in the right place. So same concept. If there is a necrosis in such a big met and necrosis in there, then you really want to avoid that. And the same patient, if you look at that, now I'm going to the pancreatic mass. So here, whenever I see a met in the liver and the pancreatic mass, I like to do FNA on both. It usually really depends on your own oncologist personal preference and your institution or system's preference, because ideally, if I see a pancreatic mass, I see a liver met, if I do a liver met FNA that's positive, 99.99% it's a metastatic pancreatic cancer. But in our system, I don't know what Mustafa, your people want. Our people want to do get a biopsy or FNA from both areas. Okay, so just to prove that it's the same process. What are going to be the likely chances of different process? But they still want that. So what I do is I go after the whatever I see first. I will go after that, but I will use a separate needle for the next one. If you do a liver FNA first and that is positive, and here in this setting, I think it's okay to use the same needle for the pancreatic mass because likely that's going to be the same process, 99.99%. But in our countries, it's a medical legal issue. So you just for the purpose of that, you want to document that you did not use the same needle really. So you can see how cellular here. This is from the pancreatic mass, and look at the liver specimen. Nothing else except the tumor. So usually they are very, very cellular, no really blood in that. Different type of needles. I think we have over here mostly access to the Boston needles, or we have access to other needles as well?
Mostly Boston, we also have Olympus.
So Olympus, Cook, Boston, Medtronic, all those needles. We mostly in our institution, we have Boston needles mostly. It's not nothing against Boston. It's not because the needle is better. It's just because of the contract. So it's a lot of needles work equally. I don't know what Mustafa uses. What is your?
I have all brands, but I primarily use the FNA needle
By Cook. Okay. So yeah. So Medtronic. That's the Sharkor is the Medtronic one, and we like everybody really has a different preference, and most of the time it is not because the one needle works better than the other. It's because of the contract and personal preferences. I personally, when I trained, and I think Mustafa too, the major needle we used to use was the Cook needle. All the needles came after that. So all of us were trained on Cook needle. And my colleague, Dr. Shaim, he says his fellowship was sponsored by Cook, but he's a major Boston needle user. Okay. So why we keep talking about the core biopsy? Because you really need more tissue, and you need a tumor cells and desmoplastic fibrosis. Because if you are talking about personalized chemotherapy, personalized medicine, or targeted medicine, then you need a molecular and genetic profiling of that. And for that, you need tumor cells as well as desmoplastic fibrosis. FNA mostly will give you a cytological aspirate, but if you need desmoplastic fibrosis, you really need to use a core T needle. So here, these are the core needles. They are made by Cook, which is Procore, Sharkor. We all talked about that, and Acquired. If you look at the Sharkor and the Acquired, the difference is it's a three prong, I should say, three cutting edges. It's a little different from Sharkor, which has two cutting edges. And so this is kind of more like a punch biopsy itself. So the both needles, all three needles are really, really work. I mostly use the Acquired needle, but Sharkor needles gives the same results. We have a comparison study on that. There's no difference on that. So all these needles work whenever you need histology. Personally, I think the three cutting edges cause a little more damage to the tissue as compared to two. You may see a little bit more bleeding with this, but we don't have any statistical difference or any significant difference in the bleeding. So this is if you compare, this is a meta-analysis comparing Procore and FNA needles, Procore by Cook. Bottom line is no major difference, except the difference was FNB needle yielded more tissue with fewer passes. Having said that, does it really give you a more tissue, core tissue, or just a more tissue? That's still debatable. So then if you don't have a on-site cytology, it may not be bad idea to use a core needle. That way at least you can have a macroscopic evidence that you have some tissue in the formalin, in the cytolite I should say, and better chances of getting some results. So this is a trial we did it, and I think it's online available in gut. You can see the difference between FNA and FNB needle. There's more median tissue with the FNB needle, more desmoplastic fibrosis, and also diagnostic cell block. All these were better with the biopsy needle than aspiration needle. So here, this is, I believe, is how to use a FNB needle. This is just that I made a video just one day before coming here. Okay, so and I told them I don't have time to edit it, so just have enough that I don't have to do any edits. So you see the mass, and earlier I showed you that if I follow that towards the tail, this is actually, let me see if, oh, sorry. Here, let me restart that. So here, you see the mass itself, you see the splenic artery, you see the splenic vein here. This is in the body of the pancreas. And I'm following towards the tail. Look at the rest of the pancreas. It's completely atrophied with with the dilated duct, but no pancreatic tissue there. So here, when we do FR, you know that the needle is going to come from here. That's mainly the arrow is indicating that. When the needle comes out, just a little bit tip of the needle, if it's going to go this way, what you can do is you can use an elevator to get in the right direction. You can see the needle is here. I will go touch the tissue, like right at the, it's not really a capsule, but right before the mass starts, and just do a dentation a little bit. And then I call it a quick, safe stab. It has to be quick, but at the same time, you don't want to get through the tumor and outside the back through the spine either. So you have to have a controlled quick stab. And if you you saw that, like it's not like a FNA needle, like you keep going 4 times in one. You really want to go only 1 time in one place, then change the direction, go to the second place. 3 or 4 are more than enough. You will have a lot of tissue in there. So it's back and forth, really 4 movements. That's pretty much it. Now, here is the thing, which needle should I choose? That really depends on multiple factors. One thing is, where is the lesion? Is it in the mediastinum? Is it in the body? I'm just talking all the lesion. Is in the body and tail of the pancreas? Is it in the uncinate process? Is it in the head of the pancreas? Also, how much tissue you need? Do you need a special staining, special studies on that tissue? And the third factor would be absence or presence of on-site cytopathologist. So I'll try to answer all those, how to address those. So keep in mind, the level of difficulty depends on the location of the lesion. The easiest one are the mediastinum. Then liver and left adrenal, then pancreatic body, tail. Submucosal, doesn't matter where they are hard to biopsy or FNA because they are usually mobile. And head of the pancreas, uncinate process, the most difficult one. And this is the corresponds to the same lesions and organs itself. And there's a reason for that. Look here. If you are in the mediastinum, look at the scope position. It's really, really straight, and there's no problem needle coming out. When you are at the G junction, same thing. When you are in the duodenum, and for the uncinate process, look at the scope position. Needle has to make a U-turn to come back. So that's why that's the more a difficult area as compared to the straight area where the mediastinum is. So not all the FNs are the same. And here, this is, I'll just go straight to the conclusion. Choice of needle mentioned about the is based on the location and nature of the lesion. Because it's easier to maneuver the 25 gauge needle, which is a smaller. So use 22 or 25 if you are in a bad position, especially in the duodenum or in the for the uncinate process. You can use 19 gauge needle. If you don't have a core needle, I'm not considering the core needle. If you don't have a core needle and you need more tissue, you can consider using 19 gauge. When we did not have a core needle, we used to use 19 flex by Boston for the duodenal, because the straight 19 is pretty much impossible to get through the scope into the duodenum. Your scope has to be really, really straight. We don't even use that anymore. I don't know if they even make anymore. They're not making much of those, not much need of those, except as an access needle now. So we have core needles and now, so don't need to.
There's no difference in diagnostic view with Procore or regular needle.
Not really. No difference in diagnostic unit.
Despite getting very good tissues,
Yeah.
it doesn't make any difference to the
This is the meta-analysis. Really, actually, this is a meta-analysis. This is one of my residents in University of Oklahoma. He mainly did a meta-analysis not on the Procore, but just 22 and 25 gauge. Yes.
That's true, because many of the time when you go into the 19 needle, actually you will not get it because it's a
Bigger needle, more blood in there. Yeah, so you are a bigger needle. You are going to use the more bloody the specimen is and less diagnostic yield. So this meta-analysis he did, and it favored 25 gauge needle and as compared to a 22 gauge needle. Easier to use, and at times when I'm having a problem with any needle, even including the core needle, and the lesion is small, and especially the bile duct ones, I use 25 gauge regular needle, nothing else, and that works really, really well for smaller and bile duct lesions. Other thing is, we're talking about rows, mows, and this is what I was talking about, pose. So we did this study actually. It's a 2-day study. We got the advanced fellows who are going into the practice, who have been practicing. We brought them to our center and we gave them a pre-test and post-test after 2 days of training. So like on their ability to assess the specimen adequacy, if they can interpret the specimen, and can they give some preliminary diagnosis. The purpose of the study was not to make them a cytopathologist in 2 days. Purpose of the study was, can a endosonographer have enough training to at least assess the adequacy of the specimen and not have to have a on-site cytopathologist. So that really made a difference, and you can see the results. Then they were much better able to interpret or at least assess the adequacy of the specimen. This is how I do it. You already heard about that. The 25 gauge needle might give you a better yield if you are comparing the FNA needles. When you take the needle out of the package, stylet is in there. So I leave that in there for the first pass. But there's really no difference taking the stylet out or leaving that in. For any solid mass, I don't like suction. We have proven that that studies, I think it's going to get published in Gut, that suction really doesn't make a difference, unless I will use the suction if I'm not getting any specimen on the knee with the past 2 passes. And I don't use a continuous suction. That's my own personal. What I do is I go into the lesion, I turn the suction on, I go a few times in there, then I turn it off, then I go a few times in there, then I turn it on, and then I do the final one. So that's how I do it personally, and that's I can maybe I can do a study on that and prove that that's the best technique too. For that one works for me. Fanning works. Avoid the central area in the large mass, as I described before. It's the presence of cytotechnician and cytopathologist. There are like multiple studies. The first one was by Dr. Clapman. He's in Tampa. I think it was in 2001, if I remember it correct. That's one first study was published that, and there was a significant difference in diagnostic yield in the absence or in the presence of a cytopathologist. And if you don't have an on-site cytopathologist, it may not be a bad idea to use a core biopsy needle if you have that available. When do you have a problem with FNAs, like when they are falsely negative? Three major conditions could be in the presence of chronic pancreatitis, or in acute pancreatitis with still pancreatitis is in evolution or diffusely infiltrative tumors. This is the main reason. If there is a lot of calcification in the pancreas right here, you see how much shadowing it's giving. And if there is a lot of lobularity there, it looks like a mass there, it looks like maybe a mass here, but what gives you a clue, you see the strands right here, you see the strands right here, and you see all the chronic pancreatitis strands right here. You do a FNA of that, you're going to keep getting up, you may consider it's a mass, you may get a chronic pancreatitis. Having said that, there may be a mass, and you may not be getting a diagnosis. It may be false negative because there are a lot of features of chronic pancreatitis. Chronic pancreatitis itself is a risk factor for malignancy as well. So the reason I was showing that is if you try one more time, maybe in 3 or 4 weeks, when you strongly suspect there is something going on, but you are not able to get the positive results what you are expecting, then try in few weeks. The diagnostic accuracy of repeat FNA is more than 60%. So when is enough means how many passes you really need, and there's a point of no return after that. You're not gonna get any higher diagnostic yields. Usually 7 passes. I talked about 5 to 7 for the pancreas, 3 to 4 for the lymph nodes. Any questions so far? This is mainly about the pancreatic cyst. Actually, I will just go over a little bit. It's mainly basically for FNA purpose. So whenever we do a pancreatic cyst, that's a whole really different lecture. You guys can read about that. But when you're suspecting a malignant or mucinous cyst or high-risk cyst, and you want to do FNA, send it for amylase, CEA, cytology, and you can do a molecular genetic testing on that. But you really need quite a bit of you really need 1 ml of fluid for that. And also, when you do FNA on mucinous, one thing you can do what we call a string test. String test is like you put a drop of that fluid, which looks like a mucin, on your fingertips in between the gloves, and then stretch it. It should stretch more than 1 centimeter and should stay there for a few seconds, that string. So that's called a string test. And this is just an example of how the serous and mucinous fluid, when you put those on slide, how much time it takes. Okay. So these definitions, you know those by now, but cytology is really individual or small group of cells, and cell block is, I don't think anybody deals with the cytopathology or have any idea about how they make the core I mean, how they make the cell block. Anybody knows that? So just not that I've been to their lab, but I know that they centrifuge that into small pellets that is embedded into the paraffin and then stained with hematoxylin and eosin. Hematoxylin is basic, and eosin is an acidic stain. So hematoxylin that stains the nucleus blue. Eosin is mainly for the cytoplasmic details. And the core is like you really getting the tissue and where the architect and arrangement of cells is preserved like that. So if you have a cytopathologist into the room and then you can do a smear of the slides just like we were making slides and then put the rest in cell block. Other option is if you don't have a cytologist present there, then you can get a lot of tissue put in the cell block. If really no cytopathology services, even in the hospital where you have to send to Aga Khan or Shaukat Khanem or somewhere else, then probably it's better idea to use a core. And these are those studies I was talking about, like which have shown that on-site cytopathologist improves the diagnostic yields quite a bit. So here I'm gonna just move on to how to smear the specimen. Again, not a cytopathologist, probably cytotechnician can tell you better, but I have a couple of videos. These are from the cytopathologist, and I can show you that. And we'll go, there are 4 or 5 slides how to differentiate the normal from the abnormal tissue. And before I go into that, any question? Somebody? Any?
Suction versus no suction. You have not explained what is the advantage of suction.
I thought I explained that like there's really no advantage, no major difference. Suction when I don't use suction in solid masses FNA. If I'm not getting any tissue, then I will use it, but we have proven that there is really no difference. Okay. Anything else?
How is there any definition of large lesion and small lesion? In quarter centimeter, you can say small.
Not really. Large lesion would be, it's not really like 2-3 centimeter. Larger lesion means usually call it where there is a central necrosis or it's more than 3 centimeter you can call it. So I did one study difference of standard technique versus just a targeted tissue acquisition in these lesions 3 centimeter and more. So we call any lesion which is 3 centimeter larger than a larger lesion. Okay. Okay. So here, how to smear it. You can see that a drop is placed onto one slide, and the other slide is just put perpendicular that closer to where it should start, and you just press it gently, and the slide is moved onto the other slide like this. It should not move or lift from the other slide. It should just slide onto that until the smear is performed. So I'll show you that again.
One single stroke.
One single stroke, yeah.
So alcohol is a drop of alcohol.
No, that's a alcohol fixed smear. That's a different thing. So this is a this way. You can use alcohol fixation. You make the same slide, then put that quickly into the alcohol. What that does is you cannot study that slide there. Usually they have to take it to the lab. It takes time, but it preserves the architecture and cells quite well. So if you do a core and you get a lot of tissue, don't just put a slide on that and just smear it. You get a little bit of tissue and touch the slide the way it's being touched, and put the rest of the tissue into the bottle, into the cytolite. You just really need a touch of that, what we call a touch prep. Don't need to, because if you smash that, that's gonna destroy the tissue. It's gonna be a clump of tissue in one one place which you can't interpret at all. So you need to be careful about that. Now, a few things about psychology. There are only 4 or 5 slides of that. So these are really normal cells. The normal, you see, all are same size. They all are kind of organized, and they are not disrupting each other's boundaries, are not disrespecting each other. All are maintaining their position. So that's how the normal look like. It's just these are the slides from our side of the politics.
I've seen these.
Yeah. So it's like
You can drive your Fiat through them.
so these slides were made by a woman. That's why these are so pretty looking fishes on there. So this is the next example. You see that the cells pretty much are same size, but they are a little bit haphazard, not completely respecting each other. So it's still like not a very a big size. If you look at the RBCs around, then these cells are not really much bigger than RBCs. So still they are not normal. It's just like a fish tank. You can see that they're not really organized. They're looking at each other, but still not really biting each other or disrupting each other. So these cells are not normal, but they are not frankly cancer as well. So they're called atypical and cells. And here, this is an example of you see a lot of fishes, and then in the center there's one shark. So you see the cells, but there are a lot of some big cells which you are seeing in there. So this one, even though there are some suspicious cells in there, but you need really more of that to prove that. So suspicion is not only quality but quantity dependent. So, and this is clearly all bad cells. Cells are 4 or 5 times the more than 4 or 5 times the size of the RBC. They are really much different sizes, all of those, and they are not respecting each other. They are right on top of each other, and here it's a small, here it's big. You see a chromatin in there, and maybe in certain areas I don't see any. Or here you see a nucleoli separately there. So all this is suggesting it's cancer. So really your goal of learning to assess the adequacy is just want to make sure you can differentiate between normal and abnormal. That's the only thing you really need to know. You don't want to give them a slide which is full of RBCs and no tissue on that. So just have at least learn, if you don't have a cytopathologist service available, try to learn that. Your staff need to learn, your techs need to learn how to make the slides, how to smear, and at least make sure there's some tissue on those slides for them to interpret for you. Okay. So bottom line is there are multiple FNE techniques. Adopt the one that works for you, and that for you, that is the best one. So whatever works for you, whenever you can get a diagnosis most of the time, then that's the best technique for you. And also, your needle choice depends on lesion location and how much tissue you need, and what are the available services. And last slide, your cytopathologist is going to tell you that he doesn't care if the needle is the lesion. He only cares if the lesion is in the needle or not. Yes, okay. Doesn't matter. And with that, I'll take any questions.
I think you've mesmerized everybody.